Well, good afternoon, my dear friends. I'm really excited to have a very special guest today with us. It's Dr. Tom Savinerich, who is a cardiologist who now is focusing more on the functional medicine approach to cardiovascular disease. And I'm so excited to have him. We're going to bring him on board in just a moment. And let me remind you that if you have a question or just a comment to make, please be sure you do it in the comment box, and then we will address it as we go along. Okay? All right. So let's invite Dr. Svinarich. Hey.
Hey, Wanda. Good to see you.
Hi. It's good to see you too. Thanks so much for being with us today.
Yeah,
You
thanks
know,
for the invitation.
I'm beginning to see more and more patients with cardiovascular problems, and I'm not a cardiologist, so I'm really grateful to have someone like you to refer my patients to. I actually referred someone to you just about an hour ago. So,
That's great.
uh, anyway, yeah, and you're already seeing one of my favorite patients. So, appreciate your help. And so, could you just tell us a little bit about how you got started in cardiology and then in your functional medicine approach to
Yeah,
cardiology?
I've been a cardiologist practicing for 40 plus years, and I was attracted to cardiology because of the excitement of the specialty. It's
Mhm.
deals with a lot of critically ill folks, and it's a lot of drama, a lot of opportunity to make a big impact in emergency situations. And that was as a young doctor, that was very exciting to me. And through many years of working with people with heart problems and performing procedures, and it became apparent that heart disease is a chronic disease, and all of the things that we were doing procedurally and with medications are very important and useful, but they don't really solve the problem long term, and we see people progressing with underlying heart disease despite of the fact that they're getting excellent medical care. And along the way, I developed atrial fibrillation, which coincidentally was the condition that I was treating the most with ablation procedures.
Oh,
And so it was fascinating to me to be, living on the other end of the stethoscope, so to speak.
and
Um,
it gets your attention.
yeah, it does. And I really didn't want to treat atrial fibrillation as in my own situation as something that was, just being suppressed by medications, and you know, having it affect my lifestyle, and et cetera. So it was an exciting time in electrophysiology simultaneously, because some really good data about the benefits of lifestyle change were being published in the traditional medical cardiology EP literature. Um, you know, atrial fibrillation, coronary disease, hypertension, you name it, they're all chronic diseases of aging, right? So they have a strong association with each other, and they have a strong association with metabolic dysfunction, visceral fat accumulation, inflammation, sleep problems, diet. So all these things were becoming on the radar. And so I took a very sharp turn at that point, and really focused on that aspect of the practice, and found it to be receiving a good reception among many people who really did want to make changes. And yeah, I don't know, want to, practicing as a physician, you sometimes get jaded that people might not be motivated to change, and that all you can do is offer them a pill or a procedure. But I was pleasantly surprised that there's a lot of positive reception to the idea of really trying to fix the problem, as well as taking care of the emergency and the symptoms. And heart disease is dangerous; people die from it. So you can't ignore the aspect of that is in which traditional medicine is applied to really help people with acute problems.
Yeah.
But you can't stop there either. So you have to go beyond. And when people are open to that idea, it's so rewarding, because they get better and they stay better. And often that getting better and staying better is just about things that are so easy and simple for them once they understand what they're trying to accomplish. And once they've gotten past some of the myths and the traditional advice that we've given people that's, too generic, based on perhaps faulty principles. Once you help people have the tools to understand what they can do to make themselves better and how they know it's working for them, not just say, oh, you should need to lose weight, or you need to eat less fat. Those are such ridiculously oversimplistic notions that no one ever benefits from that. But when people can understand that their chronic heart problems are related to metabolic dysfunction, then you can help them understand how food affects their blood sugar. If they can understand that their chronic heart conditions are related to maybe some autoimmunity and inflammation related to intestinal permeability, then you can have them understand how they can do an elimination diet to help that situation. And if you have them understand that genetics are really strongly influencing their heart problem, but that those interactions with their genetics are what really are the problem, and help them to see how to sort that out, then people will stop saying things like, oh, I'm going to die because my father had heart disease, or there's nothing I can do about it. So I think that it's really about being investigative into underlying problems. Is it metabolic dysfunction? Is it autoimmunity? Is it toxicity? Is it chronic infection? Is it premature aging or abnormal aging, or is it genetic interactions? If we can look at people's health through those lenses and not stop at making a diagnosis, then we can expect progress and participation from people.
Yeah, well, so many things that we see in terms of chronic disease processes is so, if not totally preventable, at least can slow it down so that, some of the complications don't come about. So, what got you interested in the functional medicine approach?
Well, that was the story. It was about trying to, learn more about underlying causes of the disease and what we might be able to do beyond medication to help people with heart disease.
Yeah.
So that was clearly it. My exposure to functional medicine initially was purely accidental. I was thinking about issues of diet and how pandemic really obesity and metabolic dysfunction was among heart patients. And then I stumbled across a book that I downloaded on my audio for a long car trip. And it was Jeffrey Bland's book, The Disease Delusion. And that was, wow, that was kind of like, whoa, what a different way of thinking about things, and how, that idea at that time in my career was just perfect. And that's how I learned about the Institute for Functional Medicine, started taking their courses, started to think more complementary and about medicine.
Yeah, that I got started in functional medicine by reading Mark Hyman's book. So we a little bait or whatever perked my interest quite a bit. So, so many times when a patient goes to the doctor for just their regular exam, they get their lipids, cholesterol, LDL, and everything. How do you approach a patient who comes to you with really high cholesterol and the lipids are really out of balance?
Mm-hmm. Yeah, well, it's the same idea with any kind of issue. Well, first of all, abnormal lipids are really not we think of it too much as a disease.
Yeah.
Without thinking that it's reflecting something, in the body that it's reacting to something. Cholesterol, and particularly the notion that cholesterol levels in the blood are a cause of disease is really misconstruence.
Mm-hmm.
it's the health of the particles in the blood that carry cholesterol that's important. So we measure cholesterol, and to a little degree that reflects perhaps the number of the LDL particles in the blood, but it's not the direct measurement of it. And so the closer we get to understanding what's happening with the LDL particles, how many are there? How big are they? Are they damaged, oxidized? Are they glycated? Are they in a place where they are more irritating to the artery than particles of LDL cholesterol that would be there if health was better? So when I look at the lipid profile, I'm looking for clues about underlying health. So we can see if the cholesterol is elevated, or maybe even if it isn't elevated. If the triglycerides are high, the HDL is low, well, that's a pretty strong indicator that you need to look for metabolic dysfunction. Insulin is too high and blood sugar is too high, and that's affecting the particles of LDL cholesterol in a way that makes them much more damaging to the arteries. And that circumstance is the gateway to artery disease more often than not for people. The second thing you look for are evidence of genetic issues. So we really want to make sure that if we have people with familial hyperlipidemia or familial hypercholesterolemia or combined familial hyperlipidemia, we identify those folks. Because for two reasons. One is that if they get metabolic dysfunction, it's going to make the problem a heck of a lot worse.
Yeah.
And that needs to be dealt with. But also because that isn't something that they brought on by having a lifestyle that's correctable. And often those are circumstances in which medical therapy is important. So that's an example of really probably of something we would call more close to a disease in the cholesterol panel. And then we have situations that are kind of in between. We have, the body will make LDL particles as part of its defense mechanisms. So if we're not getting good nutrition, we're not getting good sleep, if we have intestinal permeability, if we have inappropriate exercise, if we have dysbiosis, chronic stresses and infections, the body reacts by increasing its defense mechanisms. And part of that is making more LDL particles, more cholesterol. And so those basic lifestyle changes, we can recognize the need for that on the cholesterol profile at times. So those are really three big areas. I think that recognizing metabolic dysfunction on that panel, recognizing familial syndromes that are damaging to arteries, and then recognizing the effects of the body's defense mechanisms upregulating cholesterol particle production. Those are all important things that we can not just look at the cholesterol and say, oh, it's at a certain number, so you're okay, or it's high, so you better take a drug. It's so much more interesting than that if you try to look at it from the viewpoint of why is it off balance.
Yeah, so many times physicians put patients on statins at the first little sign of cholesterol being elevated without looking deeper to find out what's really going on. Do you do a lot of genetic testing on people who have really high cholesterol, LDL?
No, only occasionally, because I think those syndromes are easy to differentiate on clinical terms. Okay. And there are some situations where you might want to, look at, nail down that diagnosis genetically, but it's not the normal thing. No.
Okay, now.
Except for the ApoE4 gene. I think the couple of things that are genetically related to lipids would really be the ApoE4 variant, because it's so responsive and sensitive to lifestyle issues. Yeah. So if folks have ApoE4 variants, it's related to dementia, Alzheimer's, coronary disease, stroke, clotting, and it's very much improved by reducing alcohol and by having good metabolic health. So that's a lifestyle important genetic variant. And another is it's not really a gene, but the cholesterol profile can include a lipoprotein called LP little a, which has some genetic variability. to it, and it makes arteries more prone to have plaque rupture and heart attacks. And so it's an important thing to know about in your family history. If you have a family history of heart attacks, that variant of LP little a is important to know about. So yeah, there are some genetic issues that are commonly looked at, but we don't often need to measure the genes that are responsible for things like abnormal LDL receptors. The receptors that bring LDL particles back into the liver are often the defective element in folks that have genetic hypercholesterolemia. And if you do genetic testing, you often find that genes involved with that system are abnormal, but it doesn't really change therapy.
Now, do you ever see patients who have mild elevations? I mean, do you use statins all the time, or do you use it when you've made your lifestyle changes and it hasn't impacted their levels at all, and then you think they need a statin? Would you speak about that a little bit, the use of statins?
Yeah, in primary prevention, if someone has not had a heart attack, they don't have advanced plaque, then we're talking about a circumstance of primary prevention. So we know that a high number of LDL particles in the blood will increase the probability of those LDL particles being irritating to the artery. And then secondly, we know that the more abnormal those particles are, if they're numerous and they're small, if they're numerous and they're small and oxidized, if they're numerous and they're small and they're oxidized and they're got glucose attached, I mean, the more damaged those particles are, the more they will penetrate the artery and damage the immune system. I mean, attract the immune system and damage the artery. Mm-hmm. So, it's really about the LDL particle health and number, and not really about the cholesterol number so much. Yeah. So if someone has, a relatively normal cholesterol, but they've got evidence of metabolic dysfunction on their panel, let's say they've got, their triglyceride to HDL ratio is, 2.5 to 1. They've got an HDL cholesterol of 40, and they've got, a triglyceride that isn't even abnormal. Maybe it's 110 or 120. Well, that's a sign that things are not right. And if we measure their health of their LDL particles, we may find that their particle number is high and then the particle size is low, and that's not a healthy situation. And that's not addressed by statins. That's addressed by improving metabolic health, by making sure that the diet is not stimulating a lot of insulin production and not having a lot of elevated blood sugar after a meal. So we want to then think more about carbohydrate intake and whole real foods and fasting and ketogenic diets and things that will really help us to turn around that problem with the metabolic health. And frankly, one of that is the biggest thing. More often I look at a cholesterol profile and I'm not worried about the cholesterol. I'm thinking, number one, is there signs on this cholesterol profile of metabolic dysfunction? And in that person, the signs also would be maybe there's a tendency towards some increased waist circumference. Maybe there's a little bit of a high normal liver enzymes. Maybe, the hemoglobin A1C is not abnormal, but it's high normal. And so we want to think about health in that circumstance, and not necessarily be thinking right off the bat of making a diagnosis. Yeah. We're not diagnosing a threshold of elevated cholesterol or a threshold of elevated blood sugar or anything. We're just looking at where that person is in their health and saying, there's some signs here that your metabolic health could be better. And if it were, your artery health will stay better, right? Yeah. So that's number one thing. Number two thing is then looking if the cholesterol level, the LDL cholesterol level, is elevated. Then we want to kind of investigate further what components of that are related to perhaps, upregulation of LDL particle formation because of stress and sleep and nutrition and intestinal permeability, and what part of that might be related to, genetic issues. And that can be, apparent, or it needs to be thought through a little deeper. And sometimes what thinks it through is really assessing sleep and nutrition and all, correcting those things, and then seeing how the cholesterol profile looks after that. And again, focusing on LDL particle number as opposed to LDL level. There's a lot of healthy things that will make your LDL cholesterol level go up. Like, for example, higher fat diets, fasting, healthy oils like olive oil. So it's not really about the cholesterol level in the blood. It's really getting back over and over again to emphasize it's the health of the particles. And that number on the cholesterol panel doesn't always reflect that accurately. So we have to dig a little deeper. And if it is a situation in which there's a strong family history of premature coronary disease, the people that have genetic abnormalities in their lipid levels are quite high. The LDL particle number can be enormous. And they end up with coronary artery events, heart attacks at a pretty young age. And a strong marker of that is family history. So I think that when we're talking about looking at lipids, family history is one of those things that's really important as well.
Yeah.
So now we're encompassing a lot of things, aren't we? It's just not about the panel.
That's right.
It's about the patient. It's about the person that has the blood. And how you interpret that panel has a lot to do with looking at that person and seeing what kind of things are going on in their life.
Well, it makes it a lot more interesting and simpler in many ways.
Mm-hmm.
So do you recommend, go ahead.
Well, I was going to say the situation is very different when you're talking about someone who has had a heart attack. A heart attack is a situation in which you've developed a plaque in the artery, a plaque being a growth in the wall of the artery that's inflammatory response to that penetration of cholesterol. And if that plaque in the artery becomes what we call advanced, it has qualities to it that tend to make it prone to rupturing open. And if a rupture is open, then blood will clot right there in that spot in the artery. And that's what a heart attack is. So someone who's had a heart attack, by definition, has advanced, complicated coronary artery plaque. And then the statin drugs are brought into play there. And that's where they really shine. They don't cure the problem, but they are the only thing that has had a significant impact in having reducing the risk of a second heart attack really have been the statin drugs and the similar medications like PCSK9 inhibitors that lower LDL particle numbers. But the issue there is that it's possibly not treating the cholesterol, it's treating the plaque. And when we have tools now to image plaque, we can actually see the plaque in arteries, and we can measure how much of that plaque is stable, calcified, hard plaque that's not going anywhere. And we can measure how much of it is, kind of an inflammatory response with smooth muscle cells and collagen. And then we can also see parts of the plaque that are particularly unstable, where there's a lot of liquefaction and things that might break open into the artery and cause a heart attack. And when people are given statin drugs, the effect of that is to remove those areas of liquefied plaque and stabilize that plaque. So once a person has artery disease, the issue really isn't treating the cholesterol, it's about treating the plaque.
Yeah,
and we still use the same terminology. We say, we're trying to lower the cholesterol. But I think that we're maybe gaining insights because we have some diagnostic capabilities that we didn't have 5, 10, 20 years ago, related to actually seeing plaques, seeing the characteristics that might make that plaque stable and not going to cause any harm, or unstable and prone to rupturing open and causing a heart attack. So I think our therapies in the future are going to be directed actually toward visualizing those high-risk characteristics of plaque. There are some biomarkers that we currently use to help guide us, and then, of course, the imaging helps guide us. And really, we're going to direct our attention probably less to the numbers in the cholesterol and more to the actual effects on the artery itself. So they're really two different situations.
So you have a lot of newer type of procedures to really examine the health of the arteries.
Yeah, absolutely. There's a thing called coronary plaque imaging,
Mm.
which is not standard of care currently. It's basically, but it's not experimental either. It's just not one of those things that's accessible by traditional insurance. So the mechanism is you do a coronary angiogram with CT. So you have an IV placed, you have dye put in the vein. A CT scan images the coronary arteries, and that's a standard test that's used to diagnose coronary blockages. But the new technology takes that one step further, and that step further is to further analyze that CT for the areas that are around the outside of the arteries, and that's how you visualize plaque and characterize it as to calcified, non-calcified, and low-density liquefied plaque. And you actually see how much of it's in there. You can see where it is. You can see if it's causing any degree of narrowing in the artery. You can see if it has high-risk characteristics that make it more prone to rupture. And then, given enough time to make an impact on that, you can see if it becomes more stable looking or less stable looking over time. So that's really the revolution that we're going to experience in artery disease in the next 5 to 10 years.
Are you currently using that procedure, that investigative tool?
Yes. Yeah. Mm-hmm.
Okay. So what kind of patient would you want to do that on?
I want to do it on anybody who is interested in their artery health.
Okay.
But the problem is that you have to then be able, it's expensive, right? So you have to be able to pay cash for a coronary CT angiogram, and you have to pay cash for the analysis of it. So that can cost people, weight is currently in Denver between $1,000 and $1,500 to do that test. Mm-hmm. But a lot of people want it, and they find it to be useful because it helps them to guide therapy and to know if what they're doing is working. You might make an analogy to treating cancer. No one would treat a cancer without getting staging of it. Where is it? How big is it? What kind is it? In coronary artery disease, we've not had that ability. We've just said, oh, your blood cholesterol is high. Let's give you a drug to lower the cholesterol, and that's a surrogate for the problem of artery disease.
Yeah,
so I think we're moving into a phase of looking at the coronary disease directly as opposed to looking at it indirectly.
Yeah, it's just not enough. As I've been practicing functional medicine, of course, I learn something new every day. Every patient. I don't know what to do. I have to look it up. Study and go back and read and look at research articles. So it keeps you on your toes if you really want to help people turn their life around and decrease the severity of some of their chronic conditions. So are you currently seeing patients?
Mm-hmm. Yeah.
You're in Frisco, right?
Yeah, I'm in Frisco, Colorado.
Okay.
And I'm working at Summit Medical Center up there.
Okay, Tom just put, is that your website?
ColoradoFunctionalCardiology.com, yes, indeed. And so, yes, on the website, I do a blog every week that's a fairly deep dive into a topic. And we have a newsletter that you can sign up for on the website. And our newsletter comes out every Friday. Once a month, we do a series of Zoom meetings that focus on fasting. So it's an opportunity for the people that are interested in fasting to do it together.
Mm-hmm.
And
right.
At the same time, we also include nutrition in more general terms. So everybody who's on those Zoom calls is not fasting, but they are interested in nutritional dietary tools to help them with their health and heart disease. And many people
a great website, plenty of information, and having someone like you available for my patients that are sometimes a little bit beyond my scope of practice because I'm not a cardiologist, but having your heart healthy is kind of necessary for life
That's
itself.
right.
And so many people are so debilitated. My brother, who was actually a physician, did not take care of himself at all and ended up having a quadruple bypass. Are they doing that very much anymore? Bypass surgery?
Yeah. People still get chronic artery narrowing. So, artery disease can show itself either by a narrowing in the blood vessels that is causing symptoms because of restriction in blood flow, or it can show itself by having that acute rupture that we talked about, which is a heart attack. And the two things are very different. I mean, the heart attack is an unstable condition with a plaque rupture that can occur whether an artery is narrowed or not, because plaque doesn't always narrow the artery. It doesn't show up on angiograms or stress tests, but it's still there and can rupture open. And in that circumstance, pretty much everybody will get a stent put in. The rescue for an abrupt occlusion of an artery from a plaque rupture and clot is to do an arteriogram and put a stent in there to open it up. And that's a life-saving, necessary, important thing.
Yeah.
Now, less commonly, folks will have the situation where they've had obstructions develop. And if there are several of them, then the bypass is the most efficient way of dealing with that, to help restore blood flow to a person who's symptomatic because they can't exercise and get appropriate amount of blood flow to the heart muscle. Stents also work in that situation, but that's more often if there is just focal areas of problem. If the problem is more extensive, then a bypass is still used to restore those flows.
Well, cardiovascular disease is so preventable in terms of having those kind of problems. What would be for young people? I've got a young patient whose father obviously has genetic hypercholesterolemia. His numbers are off the chart. The father will do nothing. He's not my patient, but the young boy is I'm beginning to see an elevation in his LDL. He's like 14. What would you recommend for the children of parents who have a genetic hypercholesterolemia?
Yeah. If a young person has familial hypercholesterolemia, then it behooves them to treat that medically, because their risk window is going to be in their 30s, 40s, and 50s. And so if we have a situation in a very young adult who has that unusual circumstance, it's pretty unusual to have familial hypercholesterolemia with very high cholesterol numbers. It's not the norm. We're talking 1 in 500 people. So it's an unusual situation, but it does require medical therapy. And I would also tell any young person who has a familial issue with heart disease to start early in recognizing the problems that people get into particularly with metabolic dysfunction.
Yeah.
Because our culture it's so easy for us to have diets that are not whole food, that are not nutrient dense, that have too many processed foods, and we rely on those from convenience, accessibility, habit, and for a person who's at risk genetically, they need to start sooner and be better about that than perhaps the rest of us who can get away with perhaps learning those lessons later in life.
Yeah, having that information and starting living a healthy lifestyle for prevention wonder if anybody's ever done any studies of that, following somebody at 14 when one of their parents was affected, and you're beginning to see changes in them, if they really did as holistic of a lifestyle as possible, what they would look like in 20 years,
Yeah, I mean, it's interesting. We don't. I mean, there is there's literature that tries to dissect the issue of familial cholesterol problems, and the lifestyle changes are only going to not aggravate the problem. They're not going to correct that problem. Okay.
Mm-hmm.
So the controversy might be that if you have a familial tendency to having a moderately elevated cholesterol, say an LDL cholesterol of 140 or 150, which is pretty high up there, but it's not off the charts high as someone who might have familial hypercholesterolemia at 190, let's say, but still pretty high. And would their left to healthy circumstances, if it wasn't provoked by having metabolic dysfunction, if it isn't provoked by having stress and dysbiosis and poor sleep, would that cholesterol itself be something that would place that person at higher risk? The answer to that really isn't known.
Yeah.
But what is known is if you do poke that skunk, it's clearly going to be worse. And so that someone who's got a familial issue and their diet is not going to fully correct it, and the lifestyle is not going to fully correct it, at least it's not pushing it over the edge of the cliff, right?
Okay.
So the worst thing you can do is if you have a tendency to having a familial problem with cholesterol, the worst thing you can do is aggravate that issue with metabolic dysfunction and other lifestyle diet issues that are going to make those particles even more damaging to the arteries.
All right, that's wonderful. My goodness, so much information. And I highly encourage people to go to Dr. Svinarich's website, because he's got tons of information there. And if you're interested in seeing him, how do they get in touch? Just do the little contact.
There's a phone number on the website.
Okay.
The office number up in Frisco is 970-668-9772. And of course, the website's great access. And I think that one thing that everybody can access is the monthly talks that we do on Zoom for diet, and nutrition, and fasting. So,
can I show up?
Yeah, please.
I didn't know you did that. Okay, I got to learn new things. Okay, you're a great teacher.
Our next fast begins on Monday, February 7th.
Okay, all right.
So if anybody's interested in investigating that, join our Zoom calls and ask some questions, or listen to the comments folks have, and just join us on Zoom, and you can play or you can listen, no matter what you need.
All right. So the information on how to register for that is on your website, right?
It is, yeah. It's on the events tab.
Great. Tom, thank you so much for spending some time with us. And let's see, my other Tom, I don't see any other comments. So I'm going to go ahead and say goodbye to everybody. And I will be talking to you, Tom, about the patient I just referred to you. Okay.
Beautiful. Yeah, thanks.
All right. Okay. Bye.